Uh, this is medical trauma and the LGBTQ plus community. So Social Justice Committee is really excited to have both her lived and professional expertise on a number of topics, as you probably saw from her bio, but especially in LGBTQ plus mental health. So you may recognize Laura from all the good work that she does at Open Door Counseling and her team there. But today we'll get a little bit more knowledge about a topic that is, I imagine, quite important to her expertise-wise too. Um, just as a administrative little piece, your CEs will be sent afterward, and Laura will kind of give you a primer on what to do with questions, which I'm sure you'll have plenty. But thanks again, Laura, for making the time to share your wisdom with us here, and I'll forward it to you.
Thanks. Yeah, I'm very happy to be here. And I will do my best to make sure that this time has some tangible tools, because we're going to start off kind of big and then shrink it down to some kind of more tangible tools that our practice uses to do our best to mitigate some harm. Um, Now would probably be the time to screen share. So let me get a hold of that. Come on. There we go. Bear with me, folks. And let's see here. Okay. Can I have a thumbs up when y'all can see it? Erin, can you see it? Okay, cool. And I'm going to move Erin so we don't see her, even though her face is lovely. So I can't see my own face. If anybody has a question, I'm not going to be able to see the little hands getting flagged. So unmute yourself, please. And I'll try to answer a question as best I can. I find that I do really well when talks are a little bit more interactive. So if there's, a question that folks think will be relatively easy to answer or quicker to answer, please feel free to kind of pipe up and ask the question as I go. So as Erin said, this talk is called Medical Trauma in the LGBTQ Community. Because medical trauma comes in many forms, we're also going to be exploring access to care, discrimination around care, and the transparency that we can hopefully provide our clients for better trauma-informed care. I'm a counselor and clinical director / owner of Open Door Counseling. For the next month, we'll be located in Berry Hill, but we're soon to move to Sylvan Heights, kind of West Nashville neighborhood. And as always, folks are welcome to contact me if they have any questions after. So our objectives for today, be able to address 2 to 3 additional hurdles that the LGBTQIA population faces when seeking medical or mental health care. Learn at least one reason why health disparities in the LGBTQIA2 Spirit Plus community might exist. Don't worry, we'll address the acronym. And this includes folks with intersecting identities. So if someone identifies as a person of color, if someone identifies as being ethically non-monogamous, we'll also go over a little bit, being a disabled person or being neurodivergent, as well as being LGBTQ. Hopefully, we will also get to learning 2 to 3 ways that counseling agencies, medical facilities, private practices, intensive outpatients, et cetera, can easily adapt paperwork, treatment, and intake policy, and then learn 2 to 3 ways to potentially advocate with and for LGBTQ clients in need of supportive medical and mental health care. Also, I tend to speak rather quickly, so if anyone needs me to slow down, please just pipe up. So some vocab to get us started. I've already alluded to a couple of these acronyms. We're going to go over them. Cisgender is a term that gets thrown around. I'm sure most of the people in here know a handful of these on the list, but I'm just going to go over them so we can all get up to speed. Cisgender, for example, I am a cisgender woman. I was assigned female at birth. Cis is part of the Latinate prefix of same. So I am the same, I identify as the same gender that I was assigned at birth. Jumping down a bullet point, transgender has the prefix across from or on the other side of. So a transgender individual would be someone who identifies on the other side of the gender they were assigned at birth. QTPOC stands for queer and trans people of color. LGBTQIA Two-Spirit Plus. It's a mouthful. Lesbian, I'll just break it down. Lesbian, gay, bisexual, trans, queer or questioning, intersex, asexual and aromantic. Sometimes you'll see 2 A's, sometimes you'll see 3 A's for ally. Polyamorous is the P. Sometimes it's also used for pansexual. And then Two-Spirit. Two-Spirit, I've worked pretty heavily with Two-Spirit clients when I was located in Oklahoma. So it's a differing queer identity that is usually pretty common in Native American communities. Jumping on down. Sometimes in literature or research, you'll see the acronym TGNC, that stands for transgender and gender nonconforming. Some folks don't inherently like the idea of using the term nonconforming because what are we conforming to? So gender expansive sometimes gets put in there. We're also going to go a little bit over some medical trauma that sometimes happens for folks who identify or are in ethical non-monogamous relationships. It's a population that I work with pretty frequently. So sometimes ethical non-monogamy and polyamory can get conflated with one another, as does the phrase being in an open relationship. Like with pronouns, I've found that the best stance to take for me has been asking, what does it mean for you to be ethically non-monogamous? Because every partnership relationship structure is going to be a little different. Also with the caveat that these folks don't really have a lot of spaces where people understand what that means. And we'll break that down a little bit more. Pronouns, everyone has them. Mine are she, her, as you can see in my Zoom link. We use them without giving it a whole lot of thought. There could be a whole other presentation on pronouns, but kind of where I want to leave it is with a stat. According to the Trevor Project, which is seeing a lot of budgetary cuts, when trans and genderqueer or gender expansive folks have their pronouns used by family members, by their workplace correctly in the way that they would like them used, it drops suicide risk by more than half. And again, this is greatly impacted by I don't know if folks have seen this, but the unlinking of the LGBTQ hotline from the 988 National Suicide Prevention Hotline. It's just some things to think about in the current, in our current news. BIPOC and AANHPI. BIPOC stands for Black, Indigenous, People of Color. AANHPI stands for Asian American, Hawaiian, and Pacific Islander. Neurodivergent, that term generally refers to folks somewhere on the autism spectrum or folks with ADHD, although it is much larger than that. I could break that one down even further as well. And trauma, we will definitely get around to that. But for now, I'm going to go over some stats. Why are we here today? We're here today because over 70% of the U.S. transgender survey participants in 2022 reported having negative interactions with their healthcare providers. And this includes us. Additionally, 56% of the folks surveyed in that same survey report having an income of 25 grand a year or less, and 34% of them are in poverty. 44% of all gender expansive folks in the US survey identify as a racial minority, which is why this conversation is going to address intersectionality later, because we cannot ignore that portion at all. 1 in 3 LGBTQ youth in 2023 report mental health distress due to lack of access to care from anti-LGBTQ legislation. Just address the hotline removal, also the US versus Scrimetti decision, which directly correlated to Tennessee's impact on that. Look it up. It's lengthy. We can't address it today. And 56% of young LGBTQ folks were not able to access mental health resources. 40% of the homes that they lived in were not affirming. There was more. So we can't really address mental health trauma without talking about common barriers to care. So hopefully we're not going to go in depth on any of these. There's going to be a few that we address briefly. But access and affordability to care, lack of providers who are culturally competent and truly have trauma-informed practices. Trauma-informed gets thrown around pretty quickly and pretty loosely. And yet here we are. Fear of discrimination in medical and mental health practices, fear of police involvement and mandatory reporting, lack of family support or community support, and then one that we can very easily aid with minimal work on our ends as mental health professionals. I'm going to address confidentiality concerns a little bit later on. So these are some of the ways that we can increase accessibility in our intake process. These are so achievable. And right out of the gate, I wanted to address a few of the things that might take about 20 minutes to do. Readability of your website. I'm going to go over this a little bit on a couple of slides myself that I created here for you folks, that I actually had the question in my own mind, is this readable for folks with vision issues? And I'll highlight those slides when I come to them. If you're having a hard time squinting and reading your font, or if something, read over it. There's also a couple of apps that I've seen folks use at the top that has accessibility features. I believe Raven O'Rourke, who I refer to at the end of the slide, she's got something on her website that has that. We don't on ours. I digress. Listing ADA accessibility and accommodations for neurodivergence is really helpful. On our website, we have a direct byline that says accommodations and location. If you don't have an ADA compliant site, state it. A lot of us have offices in older houses. It's really helpful for folks to know if they've got a walker, cane, or motorized wheelchair, can they make it to your office? Listing how to access a translator for bilingual therapy or medical care very plainly. Listing what the bathroom access is like. This is, again, hard for folks in larger buildings. Is your office, does it have a single stall? Does it have male and female bathrooms? List that out. Here's another thing. Please do not report that you are experienced in working with a population or a diagnosis that you have not received specific training in. I see this a lot with folks who say they work with trans clients. I have a colleague and friend who complains also about folks listing that they are DBT adherent, where they are DBT informed. And after speaking with them, I was like, I need to change my thing. I'm not DBT adherent. So just, again, finding ways to cut the hoops that people, LGBTQ folks specifically, have to jump through, because there's already so many hoops that they're trying to jump through to get through and reach medical care. Ways of increasing affordability. Offering sliding scale spots. Helping your clients access therapy grants like Healing in the Margins or the Lotus Fund, or Open Path is helpful. If you employ interns, making sure that they are offering low-cost sessions. They are not a full-fledged therapist yet. And a hill I am willing to die on, not charging $120 a session for those interns and not paying those interns, because those interns, on my staff at least, tend to be queer or BIPOC folks who also need access to care. Also, accepting private or public insurances very much increases access to care. I will disclose that most of the folks who see me have waited to see me for 2 to 6 months. Varying stats report that approximately 28 to 50% of Tennessee therapists take one or more insurances. Imagine how low that number would be if we had reporting on folks who are competent in LGBTQ care. Another thing that helps affordability for clients is if you are a practice owner, taking less of a percentage cut or a profit off of staff's income, which then lets those clinicians charge less for clients and not have to file for food stamps. This helps, it's like there's a trickle down effect. And in a field predominantly run by women, BIPOC folks and queer folks, this is something that our agency has kind of tried to be mindful of. So moving on from the practical and getting kind of into a bigger, what the heck is trauma? Most of us have a general concept of what trauma is. Trauma can vary in lots of different ways, and we're not going to parse it all out today, but any disturbing, distressing event or ongoing chronic event that can cause emotional, physical, or mental harm. Most important thing to note about traumatic events is whether they're singular or chronic, they can change the cognition, the brain structure, and the declarative memory that a client or clients have. And what I mean by declarative memory is declarative memory kind of lives in the hippocampus, which we'll get into, but it changes how people think about the story of who they are. So these are the three kind of parts of the brain that we're going to highlight. So the prefrontal cortex, right up here, in front of the eyes, behind the eyes. The nickname I give this for clients is called the watchtower. So what this part of the brain does is it cues up stress responses by noticing patterns. And in traumatized clients or clients with PTSD or complex PTSD, studies have shown a decreased function when traumatic reminders of events or a singular event are present. So if a task requires any focus, or when, say, in session, my facial expression might remind a client of another facial expression that happened who knows how long ago, it can trigger the prefrontal cortex and kind of do a trickle down effect of setting off a trigger. The main thing that I want to say about this part of the brain is it registers either real or perceived stress responses and threats. So for example, one of the things I'll say to clients, and one of the things we work on is doing the difficult work of not invalidating the perceived threat, but saying, you are perceiving a threat in me in this room. Here might be why. Now, as a psychodynamic therapist, we're going to talk about what actually happened in the room with me and how I am feeling about you. And we can discuss how that perceived threat was real, feels real, and yet you're safe. This is also the part of the brain, the prefrontal cortex is, that Dr. Freeman, who we'll get to later, attempted to shut off and disconnect in the over 4,000 transorbital lobotomies that he gave to patients between the 1950s and at his licensure loss in 1967. The amygdala is where the conditioned fear response lives. So information travels, again, I'm not a neuroscientist, it's much more complicated than this, but conditioned fear responses travel from the prefrontal cortex to the amygdala, which then fires off what I call for clients your alarm system or your fire alarm. This is where that part of your brain that works overtime will say, this feels like an emergency. A lot of trauma therapists that I've talked with in their work with clients will use the analogy of a bear or a lion chasing a client. So if a bear or a lion is chasing you, your fight or flight response is going to kick in. There's also freeze, and there's also fawn, and there's also collapse. But the fight or flight response kicks in, and you run. With LGBTQ folks or BIPOC folks or QTPOC folks that come into my room, then the analogy that I use is your bear is constantly chasing you. Your bear is eating dinner with you. You are going to work with the bear. The bear is pulling you over and giving you a speeding ticket. How do you think that would impact your body and your brain long term? The last thing I'll say about the brain and the science that we're going to talk about is the hippocampus, which is responsible for declarative memory. It's how we make sense of things. It's how we logic out who we are in our world. And ongoing trauma and singular trauma events in the brain of folks who've experienced them have been linked to smaller hippocampal volume, less capacity to create stories, less capacity to explain what's happening. Fortunately, through things like unconditional positive regard, being in a room with a person who can co-regulate with them, having healthy relationships and environments, these can make new memories that increase neuroplasticity and hippocampal size, which is really cool. Moving on. Here's what a lot of providers look for when trauma presents itself. Generally speaking, we tend to look for hypervigilance, sudden startle response or flinching, restless sleep and insomnia, nightmares and flashbacks, anger outbursts, self-harm, or physical signs of abuse. And here are other things that I tend to look for as well. So early menstruation history is something that I very much ask folks who have a uterus, because ongoing physical or mental or emotional abuse can cause hormone disruption, which then can cause early periods. I don't think the research shows that it's causative, but PCOS and endometriosis do have some studies showing some links between ongoing chronic trauma as well as ADHD. Gastrointestinal issues, chronic pain and fatigue, sexual issues and pain during sex, gaps in memory, poor emotion regulation, difficulty in relationships, panic attacks, emotional flashbacks, self-medication and substance use and or nicotine use. Interestingly enough, bisexual men and women have the highest rates of self-medication and nicotine use, and perfectionism, chronic worry. So practically speaking, I'm going to move from here to here. Here's what my office and my clinicians assess for at intake and every 6 months. We assess for the PHQ-9, the Patient Health Questionnaire, the GAD-7, the PCL-5 PTSD checklist, which was, I think, created by the Veterans Administration. And then the DSSB, which stands for the Dissociative Symptoms Scale Brief. And this is something that I insist my clinicians do if they do brain spotting or EMDR. Now, another thing to note that I find incredibly helpful is when, for example, someone comes in and their GAD-7 reads at a 2 or 3, but the person in front of me is quaking. That's going to be really, really useful information for me because they are so consistently used to experiencing ongoing body tremors and anxiety that this feels normal to them. Um, then, in the back of my mind, what this will also tell me is that as we continue treatment together, their GAD-7 is probably going to increase, which doesn't look great for insurance companies, but I don't really care about that. What I care is that they're going to be more in touch with their body. So that is one of the reasons why we repeat these assessments every 6 months. Another reason is because insurance companies want to see progress and they want justification for why we are seeing folks every week or 2 times a week and why treatment hasn't gotten better or seemingly, I would just say seemingly. And then bringing it back home again to why we are here. These are the things that have been reported to me by clients and I've been given permission to share. Okay, but what are you? I've never counseled a trans person, so you're going to have to teach me. Because you use they, them pronouns, does that mean you have multiple personalities? Are you sure this isn't just an excuse for cheating? I can't handle the trauma you have. Have you tried prayer? You're getting cramping from estrogen? Welcome to the club. Never trust a bi man. I'll also disclose that 2 of these statements were said directly to me. Are you sure this isn't just an excuse for cheating? Was something that my partner and I had said to us by 2 providers before we found a third mental health provider that took us seriously about our open marriage. It was very difficult. And I say that as a mental health provider who knows the system, who knows how to look on Psychology Today for what I'm looking for. That was very difficult. Another statement that I will also disclose, I repeatedly get anytime I get a new PCP or OBGYN, when I disclose that I'm in an open marriage, is the doctor without fail will say, "Are you getting counseling?" Which is very kind of them to say. And it also insinuates that something needs help. Um, so that always kind of makes me chuckle. Never trust a bi man was also a statement said to me by a client, and they did not know that my spouse is also bisexual. And the reason I'm pointing this out as well is more often than not, what I hear happening pretty frequently in private practices is anytime, let's do an example. Say a parent who is wanting to address their transphobia might come to a private practice and say, I'd like help working out how I feel about my kiddo coming out as trans. Before you assign this person to a transgender therapist, please consult with a transgender therapist if they have space, energy, time, capacity to work with someone who is actively possibly going to create distress for them. So while we're talking about medical and mental health LGBTQ trauma, I also want to bring back the fact that providers who are queer are also experiencing this as well. Whew. When I was making this slide, it turned into 3 slides. There's more, and we can't get to all of it. These are just a few of the ongoing historical, medical, and organizational traumas that have created barriers for queer and trans folks coming to seek services for us, especially those who identify as BIPOC or people of color. What I did not list on here is colonization. A little big. I am a second generation immigrant from Australia. My grandpa immigrated from Australia. there's some colonizers in my background. We caused some serious harm back there. Um, Not to mention the fact that, colonizers in the US basically did away with two-spirit identities up until, they didn't do it away with it, but basically removed all the information um, from any sort of meaningful way for two-spirit folks to access. I could digress. The United States Public Health Service study at Tuskegee, otherwise commonly known as the Tuskegee Syphilis Study, um, this was an ongoing study for about 40 years. I want to say it was either Alabama or Mississippi, where there was a control group, but then there were also Black men with latent syphilis, some of whom were not informed of their diagnoses, were promised free medical and mental health care. Some of them got it. Um, and a lot of them were given either placebos or ineffective treatment. And once the study was ended, they were not informed of what happened. There's a lot more details on that. There's several great podcasts on it that are really informative. Continuing on to how the mental health and medical system impacts our diagnostic process of mental illness. Drapetomania was introduced as a mental illness before the Civil War and before the Emancipation Proclamation. Drapetomania was the diagnosis of a slave who did not want to be a slave anymore and ran away. And so they gave this a mental diagnosis of drapetomania. Henrietta Lacks was a Black woman whose cancer cells were used for research without her or her family's consent. She passed away and her cells were still used. Homosexuality was introduced as a mental disorder in the DSM-1. Funnily enough, Freud suggested that homosexuality was not a mental illness, but a deviation. Lobotomization of gay and bisexual men at Atascadero Prison in California from the 1954 to 1970. That's where Walter Freeman did some of his work. Transsexualism was in the DSM-3 in 1980. That then translated into the new diagnosis in the DSM-4 to gender identity disorder. And now in the DSM-5, it is listed as gender dysphoria of adults and adolescents, or adulthood and adolescence, with the F code of F64.9. Continuing on with our discussion of ways the mental health world still does accidental harm. If any of you use Simple Practice and you want to diagnose gender dysphoria, you are not able to. It is still listed in Simple Practice as gender identity disorder. And every time I put that in, I have to hand type it so that it does not say gender identity disorder. Genetic differences are often also cited as reasons for higher rates of diabetes, congenital heart disease, contraction and death from COVID-19 among BIPOC patients. And these, in a really large way, impact medical and mental health screening tools because a lot of tools and assessments are not normed on Black and Brown patients, especially LGBTQ Black and Brown patients. One of the reasons why they can trace COVID-19 deaths back to higher rates among the Black and Brown community is because those little pulse oximeters that go on your finger were not normed for folks with higher levels of melanin. So when Black and Brown patients went to the ER and the nursing staff would check their oxygen saturation rates, the O2 pulse oximeters read as higher oxygen content in the blood than was actually accurate. So a lot of Black and Brown patients were discharged with the nursing staff, the medical staff thinking that they had enough, they were able to breathe properly, only to find out later that the tools weren't very effective at discerning if that was accurate or not. And there's a lot more. So this is one of those slides that I was like, I don't know if people will be able to read that. speaking to insurance, and I know a lot of folks don't want to take insurance because they don't want that the pressure to diagnose. They don't want the diagnosis to follow clients along with them on their medical charts and records. But I'm going to zoom in so folks can read this a little bit better. This is part of the disclosure I give for insurance for folks who are going to be using insurance for me. I want folks to notice the bottom section most importantly. I understand that most health insurance companies require a mental health diagnosis of some kind to be attributed to my coming to see an open door clinician. I know that my open door clinician will do their best to minimize harm in this diagnostic process, but that it is a necessity for my clinician to diagnose my mental health symptoms in order for me to receive coverage through insurance. I understand this section is more for trans folks, but really anybody. I understand that due to using insurance, I may need to use my legal name that is present on my insurance card, as opposed to the name I go by. If I have another name I go by, it is my job to let my provider know, excuse me, to reflect that name in the paperwork, should I so choose. I am aware that I'm able to advocate on behalf of myself to use the name and gender that reflects my identity with my therapist, even if my insurance requires using a name I no longer go by. So this is something I called Simple Practice on multiple times. They've recently made it so that, I forget, it's not called preferred name anymore. But if in Simple Practice, for those of us who use that, there's a spot for legal name, legal first name, legal last name, and then it used to say preferred name, and now it says, I think it says name I go by, name I use. And then the only time I disclose to clients, the only time they're going to see their dead name ever is if they see an insurance claim, which I love. I love that when they log into the portal, they never see a dead name. And some folks, either don't have the means to change their name legally yet. It is a very, very, very hairy process. It takes a lot of time. Usually takes about $200. A lot of people don't have $200. Anyways, that gives folks an idea. How can we increase transparency with clients? Discuss insurance diagnoses requirements. Discuss openly what HIPAA and mandatory reporting looks like. Discuss client rights. This includes their rights around ICE. What kinds of affidavits we as professionals have to respond to, what kinds we don't, and how they can talk to us about any sort of negative experience by other administrative staff in the waiting room or other clients. I want to jump back up to the first bullet point when it says audits. So because so many of our clients here at Open Door Counseling use their insurance, one of the things I also go over with clients is their ability to advocate for themselves anytime, say, insurance requires their notes. Before, I don't know how many folks were aware of the 2023 release of records by a very large medical facility to the Attorney General. Since that happened, I have begun disclosing to clients what our policies are in case there is an audit. If insurance or some other national or state entity comes and says, we need this client's notes, before handing over those notes to anybody, before consulting with my legal staff or my legal consultation team, I will go to the client and say, hey, just wanting to make you aware, an audit has happened. And it is your right to fight back against whatever organization is requesting those notes. So it's an ongoing conversation. And I will say this to trans, LGBTQ clients, BIPOC clients, and folks who who are not in any of those groups that I just listed. Likewise, how do we report? How do we involve police? and how do we mitigate unintentional harm that we do. If something is not a 24-hour window of an emergency, please consult. Um, One of the things that has been absolutely the most helpful to me is consulting with people who have more experience than I do in other issues. I have a couple folks who I very much consult with on issues related to sexuality and sex therapy, who are actually on the resource list at the end of this presentation. Highly recommend consulting. If anybody would like to consult with me on questions around transgender care, I'm very happy to do that. I've done it before. I will not charge you if it helps with harm. Another thing that our team does on the regular is we consult with one another about, are there other alternatives to police or DHS involvement in this situation? So if something has to be reported, is there someone else we can report to prevent the need to report to police or DHS? So for example, if we know that someone has a gun at their home and there is an emergency contact or family member who can take it away, we're going to do that. The other thing that, and this is where unintentional harm gets done all the time, I know that I assume that everybody's going to report to me what's happening in their lives, but very frequently people might have an ongoing DHS investigation open. They might be on parole and haven't told me. Any number of things. They might have family members without legal status or without citizenship in their households that I don't know about. So these are all sorts of lots of intricate weavings of, we don't know the kind of harm we might do. So are there alternatives? And let's consider everything. This is the question that I try to ask too. What is the possible impact of reporting this client to their long-term well-being? And we are not going to go into that case study because we are running low on time. So here, for those of us who are slightly anxious about taking insurance, I want to give an example of what an insurance compliant note looks like that we use on the regular that also protects our trans and queer clients. And I have Alexine Batts to thank for this, who gave me the beginnings of our template. And I'm going to zoom in so folks can see better. Date of service, when it's in session, location of session. I'm just going to scroll. Make sure to look at the headings. Insurance rationale. Services we delivered. Medical necessity. Reasoning for length and or frequency of client sessions. And this is where assessing for the PCL5, the GAD7, the PHQ9, and the DSSB comes in real handy because we've got like the data that insurance wants. And when you bill a 90837 CPT code for insurance, which is 53 minutes or more, which our folks do because they deserve to get paid for their time, insurance is going to flag that more frequently and has started to flag that more frequently for those of you using Headway or Alma. And so we are trying to find ways to, pardon my French, cover our own butts. And if you notice this note template, is there any mention of gender affirming care, of the client's queerness, of transition, or of their pronouns? Nope. It's very vague, very intentional, and it is a way to protect the clients that we deeply care about. And this is another thing I will let clients know when they start with me. If we are using insurance, this is what my note looks like. And I will show them this blank template. And here's another page of the template. And so, a couple final thoughts on trauma-informed care. One of the things that I really enjoy asking on the front end when I first meet with someone, and I ask this in my intake paperwork too, but I ask face to face because I find that in tandem with the maybe the hard data that they might give me in written form, that I'm going to understand the emotions a little bit better. Um, if folks have experienced any sort of medical trauma and they feel safe enough to do so, they're going to tell you. Um, and this is part of why my passion is so big in this area. Um, I'm really tired of hearing stories of providers causing harm, and most of it's unintentional. I have accidentally hurt people all the time, and we do it every day, and we don't mean to. And there are also a few things that are very easy to do and be aware of that we can help folks with. I also find it really important to know what's helped them. Have they had positive experiences, and what was that like? What did that feel like? Um, for those of you who don't work predominantly with the LGBTQIA2 Spirit Plus community, I mean, just listen. Um, it's our first and most important job. I'm going to quote my sponsor on this one and say that shutting up has been a very difficult spiritual practice that I have had to learn at this job. And it is the one that I think is the best tool for this clientele because so much of the time, the queer community is told who they are, and how they either negatively impact other people in a in how the world sees it, or they're just not listened to. Um, so listen. Reporting an inpatient. Um, Understand that reporting suicide to police or crisis response teams without that client's knowledge beforehand can cause harm. So this is one of the things that our team does. I'm really proud of our team that we do this really well is um, before reporting, we'll have ongoing conversations about this and just say, okay, when are we going to know that line? What is your line? And how can I help hold you accountable to identify when we're there? Um, we've had counselors very badly want to drive clients who do not have supportive family um, to get a mental health evaluation. Our liability insurance doesn't cover that, but we can meet them there. And so for LGBTQ clients who might not have supportive family, who don't know how to work the medical or mental health system, be prepared to um, kind of help make those hoops easier to jump through. Um, Community. Know if your client has supportive community, especially queer community. This is one of the things that I think, especially for queer and neurodivergent folks, there can be something that's a really big, and BIPOC folks as well. It's a really big relief when queer folks can walk into a room and not have to explain themselves. So if you've got a client who's not plugged in any way, shape, or form, or even has a single friend who gets it, that can be really helpful for safety planning and just for therapeutic reasons. Um, these are some vetted resources and referrals that we have. I wish I had more IOP, PHP, and inpatient referrals. And if any folks know of any, please send them to me. um, excuse me. The tricky thing, and again, we could have this talk for a really, really, really long time. One of the things that's incredibly tricky about finding inpatient referrals that I feel comfortable, that our team feels comfortable referring folks to, is more often than not, inpatient facilities don't understand how necessary it is for trans clients or HIV/AIDS positive clients to have access to those medications. Um, but during inpatient stays at mental health facilities, those drugs generally aren't in the inpatient's what's called a formulary. So because they're not mental health meds, even though they help with mental health, clients aren't going to have access to that. So it's really important to remind clients, hey, you got to take your meds in. They're not going to have them for you. And this is where the supportive community comes in, because sometimes they can bring them to the clients if the client forgets them. There have also been cases that I have heard through the rumor mill of inpatient units making trans clients take off binders, chest binders, and rather than putting them in a shared room with clients of their gender, they will put them alone in a room by themselves, which is a workaround, and it's not great. Um, so these are the places that I can refer, no holds barred. Um, anyways, now I am going to open it up for Q&A, and I'm sure the slides will be shared, but if anyone would like to contact me, they're welcome to. And these are the references. I wanted to make sure there was enough time for Q&A, if there was any. Let's see here. Let me stop sharing. Okay. I see the chat. Will we get the PowerPoint by chance? Is that a go, Erin? Okay,
Definitely doable.
Yeah,
cool.
Laura, I emailed you during your presentation. Just send that to me.
Great.
Okay.
Thank you. I will.
Thank you.
Yeah.
I have a question. Do you work with minors and how do you do that?
I take minors on a case-by-case basis. Because I take insurance, it is very, very, very difficult for folks to find transgender affirming care for minors. And so in very specific instances like that, I'll take minors. And when I was working in Oklahoma prior to moving to Tennessee, I worked with quite a few minors. When you said, how do you do that? Do you mind?
Do you get parental consent and parental names, signatures for insurance and stuff?
I mean, yeah. I mean, working with a kid is working with a kid. Are you talking about if the kid's out or not specifically?
That's a question, always.
Gotcha. Um, That's one of the first questions I'll ask a kiddo when they meet with me. I've had it happen a few times, especially in Oklahoma. This was the case study I was going to share. Maybe now's a good time to share it. So during the pandemic, when everything was telehealth, I was doing phone calls because there was the emergency licensure allowal. And there was a 17-year-old trans kid who was in foster care, rural Tennessee, foster care with two 70-year-old extremely Christian foster parents. And I was in close contact with his caseworker, who informed me that his foster parents did not know he was trans. And without his consent, she decided to disclose that to them. I immediately stopped being able to see him. And so that is why I always ask the kid for permission. I ask the kid how we need to keep them safe. And I keep that in mind very, very, very heavily when I'm doing documentation. The treatment plan does not have pronouns listed. And I will have a discussion with the kid and say, hey, this is going to suck. But you're going to see your dead name in your chart. And that's for your safety, because we're not outing you to your parents. We're trying to get you through high school. That's part of the reason why I also don't take on younger kids. Bless Jen Strickland for doing that work. I can't have the nuanced conversation with folks. I've taken as young as 14 on as a client, but complex PTSD will make 14-year-olds incredibly verbal and acute and aware. And I would say they function more as a 20-year-old. So
I
Is that
like,
help? Does that
yeah,
answer your question?
it's just like working with any minor. I appreciate you saying that. And I appreciate
Yeah.
all that you've gone through about this. Thank you.
Yeah. The other thing I would say too, because I know they increased the age of medical consent to 18 in Tennessee. That was very planned. There was a reason for that. Um, even though they increased the age of medical consent to 18, I'm still behaving with the kid like the age of medical consent is 16. So I know I still need parent consent. I know I still need parents to sign on, but I'm giving them the same disclosures that I would give, assuming that their medical consent is at 16, if that makes sense. Okay. Let's see. Any other questions for folks, from folks?
I didn't, would you mind repeating that answer that you just gave? I didn't really understand it about, this you treat it as though the age of consent is still 16.
Gotcha. I phrased that in kind of a cheeky way. I'm going to try to be a little bit more direct. Because I am incredibly cranky with our state's treatment of trans folks, I still feel that it is in my ACA code of ethics to offer clients autonomy and decision making, even though they are 16. So legally, I do need parents to sign the treatment plans, to sign the consent forms. I'm still doing that even though they're 18 or under, or excuse me, under 18. And if a kiddo has, say a 15-year-old comes into me and says, oh shoot, I'm trying to think of an example. Say a 15-year-old comes in and says, I'm having really bad symptoms of X, Y, and Z. And I'll say, that sounds terrible. I don't really work with that particular symptom set. How would you like to go about your care? Would you like me to refer you to an affirming provider who works with OCD specifically? How would you like me to talk with your parents about referring out? So what I mean by I'm treating them like the age of medical consent is 16 is I'm just saying that I'm involving them in the discussion process as well. Does that clarify, Linda? Okay.
Yeah, thanks.
Yeah.
I hear you saying that you're trying to maximize their autonomy.
Yep. Every chance I can get. That's the other thing too that I forgot to address quite as pointedly as I wanted to. I am trying to not spend too much time in the news, but for those of you who are up to date with how our nation has handled immigration, we have changed our policy on signage at our offices, and actually we are moving our offices for that very reason, because we're in a co-sharing space. Anytime a new client starts with me, whether they are white, black, brown, queer, cis, you name it, I'm showing to them the sign that is at the front of our door that says only authorized staff and clients are allowed. And then I point out to them and say, the reason for this is that if immigration or anybody who's not supposed to be here comes in, you have an extra layer of protection to fight back. So just, there are lots of little different ways to kind of just show them that you're paying attention, even if you don't identify as a member of that community. Yeah, increasing autonomy when we can.
I don't really have a concrete question so much as I've got really stuck on what you said at the end of your presentation about the resource list and referring like options for high acuity
Mm-hmm.
levels of care because
Mm-hmm.
that's my treasured population, and I already felt that way about finding trusted inpatient IOP, PHP recommendations
Yep.
because medical trauma there for BIPOC and LGBTQ plus populations, but also just people with going through crisis in general as well.
Yeah.
It was already tricky to justify other than trying to keep themselves safe. But a lot of the things I think you mentioned today, it's like it's a really tough position I think we're in as clinicians
Mm-hmm.
to weigh the pros and cons of like say you are working with
Mm-hmm.
uh, someone who is an immigrant and they're in a crisis situation
Mm-hmm.
and you need to involuntarily hospitalize them. How do you do that in an ethical way? Like the
Yep.
most ethical way in this current context. So
Right.
you've
Right.
generated a
And
lot of thought.
oh yeah, and I think the tricky thing about having like just an hour of time is we didn't even get to the overall impact of things like the Henrietta Lacks cancer cells or the Tuskegee syphilis studies impact on how those communities then view the medical community. And how, not only is it harder to access care for folks who live in poverty, highest rate of that being trans individuals, most high being trans female individuals of color. So then who's their supportive community if they've got mental health issues? If their entire community is also a community of color who doesn't want to access those mental health facilities of any kind, because we don't do that. Yeah, yeah, it's frustrating.
Um, this is may sound like a sort of a stupid comment, but everything you're saying, which is so heartbreaking, Laura, which is so sort of horrifying, I put in the context of that we're in Tennessee.
Mm-hmm.
You know,
Yep.
just that alone, in terms of what people here are having to cope with, apart from all the other things that you've mentioned.
Mm-hmm.
It's like being a hunted animal or something, in a state where it's hunting season.
Mm-hmm.
Um,
Well, and the other thing that I don't think I mentioned is what the state of Tennessee is also starting to do that isn't making news coverage is it's going back to trans individuals who have state insurance and have received gender affirming care surgeries and saying, pay us back. You got care 5 years ago for a phalloplasty or a top surgery. You owe us 10 grand. We changed our minds. So then you've got these folks who have had insurance coverage, thought it was paid off, and are getting these really large bills of 10 to 20 grand. After a lot of folks don't know this, anytime there's genital surgery of some kind, it can take years because folks with lower bottom surgery or genital surgery of any kind requires electrolysis, which is a series of weekly appointments of hair removal to prep the area for surgery. Phalloplasty takes about 3 to 4 different surgeries. Vaginoplasties is more. It's a lengthy process. People don't just walk in and walk out. They also have to get 2 letters of gender affirming care approval from someone like myself. And if it's top surgery, it's just 1 letter. If it's lower surgery, it's 2 letters, one from a PhD or a doctor. Each of those letters can cost $200 depending on the provider. So you're looking at about 20 grand and maybe 5 years worth of work. So if anyone needs free letter writing, that's something that our offices offer because they've got enough expenses. So yeah, it's heartbreaking.
Has that been challenged in the courts? You have to pay me back for something that was at the time accepted by insurance?
So that is something that I have navigated with clients and saying, I am on your team. I can direct you to legal counsel who might be able to help you fight this. Do you have the energy to fight this? I will fight this with you. And more often than not, the answer is I'm tired, which then returns us back to the amygdala being really tired of getting chased by the bear.
Yeah.
Yeah.
How do you maintain your own sanity?
I have a wonderful spouse and a supportive family who doesn't quite get why I do what I do. And I have my own therapist. And I love it.
Mm.
I love this work. Good question, though.
Does your organization have in-house peer consultation, or are you in a peer consultation network outside the organization?
Do you mind defining peer consultation? Just like,
Support for the therapist, it's not individual therapy.
gotcha. So I try to keep about 2 to 3 hours on my schedule open every week so that if people want to meet with me, they can. We have an hour-and-a-half staffing meeting where we staff with one another and we staff cases. We also have a pretty good relationship with Pasadena Villa. They consult with us on transgender related cases that they want to handle well. And we tend to consult with them on folks that we think are kind of teetering between needing higher acuity and maybe can see one of us twice a week. Most of our clientele have a PCL5 score of 35 or higher. I would say probably about 50 to 75% of our clients have PTSD criteria met. And then all of us are in our own peer consultation groups because this is how we do it. Any other questions?
You did have one in the chat about your safe referral list.
Oh, thank you. Let's see, safe referral list. Yes, it's in safe referral list is on. We also have one on our website. And what I would say specifically for LGBTQ clients and folks who might have any sort of open or poly relationship, there's a couple on that list on our website that I wouldn't recommend those folks to, just because while some folks might be very gender affirming or BIPOC and queer affirming, they are very shaming around sex and any sort of sexual thoughts that might bother some people. We have someone on staff, she's phenomenal. She's getting her ASEC certification and she treats OCD. Her name is Sierra Tuck, and she sees a lot of folks who have intrusive thoughts around sexuality. And she sees a lot of trans folks. And so the intersection of that is really difficult to find referrals for. So the slides have a good list that I'll send out.
There used to be many, many years ago, a KAP, Kink Aware Professionals Network. I don't know if that still exists.
It does.
No, it does. Okay.
It does. Yep.
Okay.
Madison's nodding.
Still there.
Yeah.
Yeah. Okay.
It's still there. It's really fun. So there's I don't know if you'd call it a sex dungeon or a group meetup location, but right up the street from us is something called The Mark. And it was Dolly Parton's former recording studio. She sold it to them knowing what it was going to be. And there's actually some really helpful support groups. So they actually have a support group called Kinky Christians, which is my favorite name. They'll give folks tours. If you feel like you've done enough appropriate training, they will have business cards for kink aware professionals. They also have safety related trainings for folks who want to get into poly E&M relationships but don't know where to start. So they're great. It's pretty much volunteer led too, from my understanding as well.
They've also done a lot of training for the community, and I think maybe even for MPI in the past. We had tours and
Oh, cool.
I know Laurie Miles mentioned them, I believe.
I haven't looked at your website yet, sorry. Does your website also have online helpful resources of like good online support groups for trans folks, for ethical non-monogamy folks, poly folks? Like there are a number of really good online support places. Do you refer to those? Are you aware of those?
So many of our clients are so much more aware of the online resources than even we are. And so usually I don't have to find those support groups for them. No, short answer to your question, our website does not have support groups listed just because we've wanted to keep the people who run those groups safe because usually they are also members of the queer community.
Yeah.
We tend to refer to folks who are local so that local, and I know that they're comfortable with their info being disclosed. And we tend to do that on our Instagram page because stuff changes all the time. Oh, thanks, Erin. Deanna said, I think you referenced the large medical institution that released medical records. Were they also listed on the safe referral list? This was an area of difficulty of me listing them on the safe list. Yes, they were. It's complicated. I have not had a queer, trans, or BIPOC client go into Vanderbilt inpatient and experienced harm around identity yet. That is not to say that there has not been larger medical trauma that has come into play. The difficulty we find on staff is that a lot of the Vanderbilt medical practitioners are really wonderful. The folks at Vivid are great. The system as a whole is not geared towards treating clients like ours very ethically, legally sometimes. So yeah, it's on the list because we don't have another IP program. Yeah, Linda.
Here's another naive question. Would you define the kink affirming network?
Yeah, I'm not a member of it. The group, do you mean the kink aware professionals that Betty brought up? My understanding, and correct me if I'm wrong, Betty, it's essentially a network kind of, I mean, it would be like a larger version of NPI, a group, a database of professionals, massage therapists, doctors who understand and aren't going to shame folks involved in the kink community.
And define the kink community for me.
Kink community. So folks who are into kink community. There are so many different kinks. We need a whole different session, but BDSM, role play, submissive dominant folks who are interested in what's called puppy play, just any sort of what the medical and mental health community terms sexual deviance.
Okay.
So the notion of the network back
Yeah.
in the day when I was a participant in the network, but I don't know that I'm active. It was that you won't define someone having, I have someone who likes to go to dungeons and get beat up. And
Yeah.
I wasn't defining that as a mental illness. He wasn't defining that as a mental illness, right? So it was an awareness that is a thing that people do, And there's a
Yeah.
way to check in with them around what's that about and what is that, the meaning of that for them? Is it a focus of treatment or not? And if it's not, it's just a fact of a thing that they do. And, it can be talked about without it becoming, oh my God, we have to talk about that all the time because I've decided that that's just weird. And if you're feeling okay, you won't do that anymore. Right. So,
Yeah.
So the kink aware professionals, just awareness that there are a range of things that people do that are, if they're consensual, age appropriate, safe,
Yeah.
right? They're a way to check in on that kind of stuff. And it may or may not be a subject of the session, but they may say, a thing happened to me last week at the dungeon and I need to talk about it because I'm upset about it. And well, you shouldn't be going to those dungeons because those are gross places, right? Like you don't want a therapist who's just kind of blown away and can't bear it. So that was sort of the kink aware professional network. And if you have a massage therapist and you come in with bruises and you're into impact
Yep.
activities that leave bruises, that's not a reportable thing to the police or something. It's just like, yeah, you wanted that bruise and you're okay with that. Right.
Yeah.
So
That's very helpful. Thank you. But it seems to me what we're saying is, how big is your paradigm? How big are your paradigms? Or how narrow are your paradigms? In our state, most of everybody's paradigms are pretty small. And that's why these people are in such danger so much of the time. Yeah.
Well, and going off of what Betty's saying, that's, I work pretty largely with trans folks, and I'll repeat kind of what Betty said. Most of the time, I'm not spending sessions talking about people being trans. I'm not talking about their visit to the doctor or their hormones. They're seeing me because I know that towards the end of their weekly hormone injection, their mood's going to drop and plummet, and they don't have to tell me that. They don't have to educate me on what estrogen or spironolactone is. We're just doing therapy. So kind of same thing with the kink aware professional, like as a trans affirming professional, I'm not making the session about them being trans. I'm not pathologizing them being trans or queer or in an open marriage and associating that with trauma, because so much of the time, any sort of identity deviation from being cisgender, heterosexual, white is associated with trauma. And these two things are not the same. But that is why I specialize in trauma, because so much trauma is done to this community. It doesn't go the other way around. And a lot of folks assume it does.
What do you mean it doesn't go the other way around?
well, it can. There are movies like what was that movie that with the kinky movie that everybody was saying that the guy was I don't
50
remember.
50
Oh.
Shades.
50 Shades of Grey. Like he's into doing all these things, but once he's okay, he won't need to do those things anymore. So people only do these things because they've been traumatized, or people are only gay because they've been traumatized by opposite sex, or there's just a lot of. Is that what you mean by not going the other way?
Yeah, thank you.
People can have trauma and have all these things, but
Yes.
the causal nature of that is not assumed. It could correlate. There could be lots of things that can correlate with lots of things, but.
Thanks for translating. That is exactly what I was trying to say.
Is that what you meant? Okay, I didn't want to.
That's exactly what I tried.
I was just thinking that because of popular movies and the popular understanding of especially extreme kink is that has to be because that person is really fucked up, and not that that's a recreational thing that has, and they may or may not be fucked up, right? Like so, but it isn't like if they get okay that they won't want to do kinky things anymore is not necessarily true.
Yeah, it's kind of like what they used to do with gay people, to change them. Like they must be wrong with them. Yeah.
That almost made the list. So part of the reason why homosexuality wasn't removed from the DSM-5 until it was to allow organizations like Exodus and Jonah that talked about conversion therapy, basically large conversion therapy programs, lobbied folks in the DSM to keep homosexuality as a minor diagnosis so that it would still be legal and ethical, not ethical, legal to still perform conversion therapy on folks clear up until the 80s.
In the DSM, I think it was 3. It was called ego-dystonic
Thank you.
homosexuality.
Yes, it was.
That
Good
was when I was
memory.
in graduate school. I'm that old. It was still in the books. If
Wow.
you don't want to be gay, you can be treated for that.
Right.
But it was
Because it's
also to get insurance to pay for it. It had to
right.
be.
Right.
Yep.
Yeah. It's so interesting.
That's fucked up. Jesus.
Hmm?
I said that is fucked up.
Mm-hmm.
Yeah, it gives me cold chills. Some of the stuff that we're talking about gives me.
What's interesting is that one of the psychiatrists who was on the DSM team, who was developing the newer DSM, was a gay psychiatrist. And he had to come out in the process of doing all of that to try to continue to, this Pride Month, happy Pride, everybody.
Happy Pride.
Kind of decriminalize, depathologize homosexuality, even to say ego-dystonic homosexuality. It's like the gender stuff is coming on following on the path of that.
Well, and in the list of ongoing medical and systemic traumas, we talked about the prefrontal cortex, the transorbital lobotomies for gay and bi men, but we also I didn't have time to talk about the lack of diagnosis of postpartum depression and psychosis and bi and lesbian women who then got institutionalized. So a lot of queer women would get institutionalized in medical facilities, my grandma being one of them, in the same hospital as One Flew Over the Cuckoo's Nest, and received electroconvulsive shock therapy treatment, while the gay and bisexual men, when men are deviant, they get criminalized. When women are deviant, they're institutionalized. Yeah, I can't remember who said that. I think it might have been Audre Lorde. I might be misquoting her, Angela Davis. Yeah.
And notably, in graduate school in the 1980s, none of this was discussed. Everything I learned about LGBT community, the kink community, all of that was continuing education from seminars and other people.
Yeah.
And clients who came to me and said, you don't know anything about this, go find out.
Yeah.
And I did.
My graduate school in Seattle didn't cover same-sex relationships. And so I actually left and finished grad school in Tulsa, Oklahoma. And the director of the program specialized in transgender healthcare, which is why I'm here. So
good. Things are moving.
Yeah. And I think that that's the other thing too, that's wild is, I want to say 1/3 of all queer and trans folks live in the South, and the providers are leaving. So folks who don't work with trans folks, please come work with trans folks. We need you.
Laura, can I ask one more thing?
Yeah.
I'm not sure how to state it. It seems like we were making all this progress and then we've been going backwards. And I just wondered what your thoughts are about that. It was like our paradigms were getting bigger and then all of a sudden they started shrinking back down again.
My question would be progress for who? Because I think there's been progress for people that look like me. I've got the benefit of being with a man, even though I'm queer. Progress, yes. But I think each generation has something that it's not figured out yet. The 1960s were the civil rights movement. I would argue we're still there. So, I mean, has it gotten better in some ways? Sure, but better for who?
Better for white supremacists, let me just say that.
All right, as we're coming upon 7:30, I keep wanting to interrupt saying that's a good note to end on, and then we keep getting other ones. But any final thoughts or questions or statements?
Just appreciate you doing this tonight.
Oh,
This is-
yeah, totally,
I,
Laura.
I can't make it to the noon lunches, so I'm happy that you did this and that you did this in the evening so we could join you.
Thank you so much.
I appreciate your experience and expertise.
Thanks.
A lot, yes.
Thanks.